Vaishnavi? Okay. So the WHO definition of palliative care is that it's an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness, and the prevention and relief of suffering by means of early identification and assessment and treatment of pain and other problems. So that includes physical, psychosocial, and spiritual. I would add that not just life-threatening illness, but also life-limiting illnesses are something that we need to consider. And if you look at the last sentence, physical, psychosocial, and spiritual, no one professional can look into all these different aspects. Okay, so to achieve the above, a care team needs to work together, utilizing an interdisciplinary approach to provide and implement a care plan that meets the patient's and the family's goals and needs. At this point, I'm going to give you a little bit of an example with an ongoing case that we are seeing. We have in our care a girl from who was with us in our children's program. She came in when she was 12. She's now 17 years old, and has been associated with us for a few years now. Okay, sorry. I just have a message saying that my video is being switched off. That's fine. That's all right. Okay. So the problems are manifold in this family. One is that the child has rheumatoid arthritis, which causes her quite a bit of pain. The mother is a daily wage worker. She doesn't make more than 200 rupees a day. The father had, there were several problems with the father and the family, including domestic violence. He was also an alcoholic, is an alcoholic. And then, of course, there is another sibling. Now, the interdisciplinary role becomes quite obvious in this regard, because we had her recently come in for a review. She's now, like I said, 17 years old. And we found that she was not going to school because she was in a fair bit of pain. And she felt that if she had a pain episode in school, she wouldn't be able to handle it. The mother's concern was that now that this girl has come of age, there was a lot of attention on her in the neighborhood that they were in, which was not a very safe neighborhood. And the mother was concerned for the daughter's safety, and it was a constant source of anxiety. The father, having had a stroke, is debilitated and at home, but that does not stop him from continuing with being an alcoholic. In fact, now he has men coming across to the house to provide him with the alcohol. And of course, the mother is also very, very concerned that the boy, the sibling, is being neglected in all of this. Over and above that is the problem that whatever money is coming into the home, the father tends to take away and use that to spend on alcohol. Now, when we had this girl come in for the review, we had several people talk with her. One was the doctors. They reviewed her pain, they reassessed the medication, and they started her off on a new prescription. We spoke with the mother about the possibility of moving her to a school that was closer, and even if the date for admission was over, we've spoken to the school authorities, and they've agreed to take the daughter in. We have helped them. Now the social workers spoke with them, and a new home has been identified in a new, safer neighborhood, which is a huge relief to the mother. And I think they're going to be moving there soon. And finally, we have also got the mental health team involved in order to sort of try and help deal with the father's addiction issues, and also to deal with the domestic violence issues. Now, I don't think this particular case could have been solved by any one discipline, and it required everybody. And now, a very important part of that interdisciplinary team is our volunteers, because one of the things that the girl expressed was her desire to learn English and to get better at it. And so what was then decided was that one of the volunteers who lived closer to her area would give her English tuitions every week. So that's something that the girl is also now very happy about. So this was, I think, a true interdisciplinary effort, and that sort of just demonstrates how you can improve the quality of life of the patient and the family by having a complete holistic approach like that. Next slide, please. Now, I just want to quickly check how many of you are familiar with the idea of total pain. Have you heard this concept? Have you heard about this concept? Vaishnavi, I can't see everybody, so you're going to tell me if anyone is raising their hands.
Anybody is having any comments, please raise your hand so that we can unmute you. Yeah, Amrita Ghosh. Amrita Ghosh has some suggestions and comments. Please listen to them. Yeah, please, Amrita, proceed. Amrita, can you hear us?
Hello, ma'am.
Yes, yes.
No comments, ma'am.
Oh, okay.
Okay, all right.
Okay.
Okay, so total pain, as is mentioned, there's the idea that the way a person experiences physical pain and distress is significantly determined by his or her life circumstances. What does that mean? We're all taught to measure pain, to ask a person what the pain is on the pain scale. And there are times when outside of palliative care, I have actually noticed, when a person is asked, when a patient says he's in tremendous pain, sometimes the healthcare provider is disbelieving that the pain is actually that much. Oh no, he's not got these symptoms. He's not, his heart rate is not up. This is not happening. That's not happening. So if the patient is saying it's an 8, you know what? I think it's actually a 4. That does happen. That does happen when we don't think that, or we think that the person is exaggerating his or her pain. But I think in palliative care, we tend to give the patient, we believe the patient when they express a certain pain scale. Now, for instance, I'm going to ask all of you, when you have a headache, suppose you've woken up with a headache and you have to go to work. And on the day that you've woken up with this headache, you have a deadline that you're running behind on. Your car breaks down, or your scooter breaks down, or the auto breaks down.
Smriti ma'am, are you there? Yeah, due to some technical errors, Smriti will be back. We can wait for a few seconds. So we have a few more people have joined in our sessions. I think Sana and Bashisha. So we were talking about the interdisciplinary team efforts in palliative care. So SMRITI Rana is taking the sessions. Due to some technical errors, she lost the network connection. She will be back very soon. So those who are joined, you can see the shared slide here. Yeah. Hi SMRITI ma'am. Hope you are.
Yes, I'm sorry.
Oh, no problem. Proceed ma'am, please. Thank you.
All right. So I'm not sure what the last you heard was. Vaishnavi? Can you hear me? Is it audible?
Yes, yes.
Okay, so I was saying, I don't know what the last thing you heard was.
No, actually you were saying about total pain and the idea about the holistic approach.
Yeah, so I was also saying that, you on the first, I want to present 2 scenarios. And in the first scenario, where you have a headache and you're late for work, your transportation has broken down, you've had a fight with someone in the house, your child is sick. And the second scenario is you've woken up with a headache, you're allowed to stay home, you have someone looking after you, and you can be rested. And the question here is, how would you feel the pain to be worse? On the day when, yeah, Vaishnavi.
Yeah, those who have any answers, please raise your hands and you can say your opinion. Yeah, she raised a question, what will be the situation for that particular person and how he's going to manage. So anyone has any?
On which day will the pain feel worse?
Yeah, Pranab Kumar sir.
Actually, during this period, can you hear me?
Yes.
Uh, I will manage by myself with positive outlook. So the pain is there. I will take medicine, but I will be resting. But one thing that I must think positively. Don't think in a negative way. If I think negative, then the pain will increase. I think so.
Okay. Thank you. Thank you, Mr. Basu. The question, though, really I asked is, on which of the 2 days would you think the pain would feel worse? On the day when things have gone wrong drastically, or on a day when you have rest and you have people to look after you and you don't have as much stress in your life?
Yeah, Runa
When
is having some opinion. Runa, please.
Hello. Can I audible?
Yes.
Okay. First of all, this situation, I am very much angry because my pain and lots of work. And second thing, after that, I am being frustrated what I will do, and I think that's the pain. And I need to work complete. It's the situation is very pathetic. What I will do?
So are you saying that it's the day that there are a lot more stressors that you will
Yes.
feel more
Yes,
acutely?
yes.
All right. So that typically, in a nutshell, is what total pain really is. On the days, pain is a subjective experience, and it relies largely on what is going on around you at the time. If there are stressors, if there are other worries, if there are other concerns, then the pain is going to feel a lot worse. Any symptom is going to feel a lot worse, depending on various other factors in that person's life. Next slide, please. Okay, like I said, no single expert can address the needs of the patient and the family. Next point, please. Now, yeah, you can just list them all out. So when we look at a patient, we're looking at pain and other physical symptoms. We're looking at the social situation. We're looking at the financial situation, psychological, spiritual, and cultural. Now, that is typically what palliative care aims to do, to reduce suffering by addressing all these different factors. Now, as non-medical clinicians, our job is also to look into the social situation. How is the person living? Is the person isolated? Does the person have support? Does the person have some sort of negative dynamic with a family member? What is that person's financial condition? We know that healthcare costs drive lots of people to poverty, to multi-generational debt, to financial ruin. And that is a story that we see pretty much everywhere that we go. So what is that person's financial situation? Have they taken a loan now that they're going to have to pay back and don't have the means to? How is the person psychologically coping with their situation? And what is the impact on the person's psychological well-being? Spiritually, are they questioning the meaning of their life, of their existence? Are they questioning why this is happening to them? Has it altered their relationship with their God? Do they question their belief system now? And culturally, where are they placed? We have several communities which we're going to be talking about as we proceed with this series of echo sessions. Lots of people are marginalized because of the communities that they belong to. People from LGBTQ communities, prisoners, sex workers, migrant populations, tribal populations, geographically isolated people. So there are a lot of cultural factors that come into play as well, and stigmas associated with certain diseases and illnesses. So when you look at, if you want to help a patient and their family, then we have to look at all these different aspects. And for that, we need different kinds of expertise. We need different kinds of disciplines converging together to address the problem comprehensively. Okay, so healthcare professionals have a shared role in providing person-centered care. So that's what the gist of the interdisciplinary approach is. Next slide, please. Now, the benefits of an interdisciplinary approach is that when two minds are better than one, three minds are better than two, and the best possible outcomes are achieved through a consultative, collaborative approach. Team members come together, they sit together, they bring their expertise to the table. The doctors and the nurses will talk about the medical side of things, the care side of things. Social workers can bring to the table socio-economic, financial, emotional issues, family dynamic issues. And we will be talking about who makes up the team in the next slide. So various people come together to the table, discuss what the plan of care should be, and then come up with the best possible plan of care that will reduce the patient and the family suffering as far as possible. It also improves healthcare processes. Different disciplines call for a variation of documentation, of protocols, of process maps. And when we bring all these different kinds of systems together, definitely there is an improvement in the processes that we follow, and also the level of satisfaction that as a team we have achieved this, that also comes in. It has been scientifically proven. There is evidence to show that an interdisciplinary approach, when it is done correctly, can actually reduce the length of stay in a hospital and avoid duplication of assessment. If you have a functional interdisciplinary team, one of the most brilliant examples I saw recently was in KMC in Manipal with Dr. Sheetal Raj's team. They have, of course, an interdisciplinary team that is robust, and this is something that we see across different scenarios as well. The physician will assess the patient. In the meanwhile, the counselor talks with the family, after which the counselor will talk with the patient separately and then have another family discussion together. A physiotherapist will come and assess the person's mobility and various other factors. We have the social worker that comes in and looks into different aspects. And we have a pharmacist who also comes in and checks the medication that the person is on to make sure that there's no duplication of drugs even. And if the drugs that the person is on currently have any side effects that might be affecting their quality of life, and if that dosage needs to change. So overall, it's a very, very well-rounded assessment. And finally, the patient actually doesn't need to spend that much more time in the hospital as he or she would have had to otherwise. And finally, more comprehensive and holistic records of care. Now that is important. Quite often you see, case files just being symptoms, the diagnosis, the symptoms, and the medication. And probably the schedule at which the medication was administered. Those things don't really tell you much about the person that you are dealing with. It tells you about the disease. It tells you about the illness. It tells you nothing about that person, who they are, what their hopes are, what they wish for themselves, for their families. It doesn't tell you any of that. Healthcare nowadays tends to hide behind statistics and numbers and readings and things like that, but I think it's the stories of people that really tell us how we can help them. If we sit down and we listen to their story, and we understand where they've come from, what their experiences have been so far, what their worries are, what are their concerns for the future, for their children, for the present, what anticipatory fears do they have, if we learn all those things by listening to them, that's when we can really help the other person as a human being rather than just a container of disease. And that is really what palliative care aspires to. So holistic records of care are very important. Just as much as the medical records are important, psychological notes, physiotherapist notes, mental health notes, all of those things have to come into that person's assessments and plan of care. Next slide, please. Who makes up the interdisciplinary team? Now, please go on. Okay, so health professionals from different disciplines working collaboratively. I mean, that is pretty self-explanatory, that sentence. The team works in a coordinated fashion towards a common plan of care for the patient. So typically an interdisciplinary team will meet at least once a week, review the cases, especially the challenging ones, and then on a week-to-week basis, the goals will change as per what is being achieved. So the common plan of care will be arrived at after different people on the team have talked about the areas that they are experts in. And for instance, now in the case of this child that I told you about, it was after a discussion that we had that we decided what was priority. What could we do to help this family? Of course, the pain needed to be managed immediately, but the concern with that neighborhood was a very, very big concern. And so that became a priority issue for us to look into. Let's find her a house that she feels safer in. Now, once she feels safer, once she's out of that neighborhood, once the mother and the family are out of that neighborhood, it takes care of some other problems as well. For instance, all these other, some of the men who were hanging around in that neighborhood, who were sort of stalking the girl and stuff. By moving out of that neighborhood, even that problem is eradicated. The father's access to the alcohol was also significantly reduced because these men were no longer around. And also the school issue, to get her back into school. So it's only once we all spoke with one another, we were able to prioritize what that plan of care should look like. And we were able to come up with a coordinated effort, which was quite seamless. And I think within a week, we were able to address a lot of the problems that that family was facing. Share responsibilities and promote role interdependence. An interdisciplinary team does not mean that we only stick to our areas of expertise. It is also a learning experience. We learn from our colleagues. And while I may not be able to do what a doctor does, there's a huge learning and there's a huge opportunity to understand what the other person is doing that is helping this family tremendously. And there is interdependence in the sense that if I don't need to be a doctor for the doctor to explain to me that, hey, you know what, the medicine that this patient is on right now could be causing these side effects. And so that is definitely something that all of us need to be aware of. Now, as a psychologist, if I'm told that that particular symptom may be just a side effect of a drug, then I'm less likely to worry about it being a mental health symptom, although I will assess that. So there are various ways in which this converges, and it's important that the team shares information with one another that might be relevant to the other person's role responsibilities as well. If I, as a psychologist, detect or discover that there is a particular mental health issue in the family, it may not be the patient, but it could be in the caregiver, then I need to explain that to the doctors and the nurses, because if somebody else, if the caregiver is having some struggles, then the team as a whole needs to know that that caregiver cannot be the one who's dispensing the medication to the patient for the time until he or she is also given adequate help. So those kind of things. And finally, respect individual members' experience and autonomy. And this is a very, very important part of the interdisciplinary team. I'm sure all of us have at some point experienced that, especially in developing countries, there tends to be a hierarchy in the team. It's an unwritten hierarchy. And the hierarchy usually has the doctors and physicians right on top. Then come the nurses, and then come everybody else. And usually the social workers and non-medical clinicians are in the bottom half of that hierarchy. It's an odd thing, but it is there. It is culturally there. But at the same time, I feel that there is a huge need to shift that to a more egalitarian system, because as much as the doctor or the nurse bring to the table, non-medical clinicians also fulfill very, very vital roles in this team. Very often we find that the solution to the family's greatest concerns lie in a non-medical intervention. And that is something that we work hard at in Pallium India. And I think Sherin will be addressing that a little bit more when she talks about the role of the psychosocial clinician and the social worker on the team. Very often, social workers have to remember to value their own work if other people are to value it as well. And that is something that is a constant, that's a thing that we constantly encourage, and to respect your work and value it so that other people will do the same. Okay, next slide, please. Who makes up the team? Go on, Vaishnavi, you can keep going. So you have doctors, nurses, pharmacists, social workers, mental health professionals, art and music therapists, occupational therapists, physiotherapists, volunteers, palliative care assistants, caregivers. That's a pretty big team. But people engage as and when required. It's not like all our interdisciplinary team meetings has all these different people sitting in there. I think at some point, Vaishnavi, we should also add, we have people who advise us legally in certain cases. They may not be part of the interdisciplinary team on a regular basis, but very often in India, when we find that a family is in a particularly difficult situation, we need to know what the rights of the child are. We need to know what the rights of the mother are. We need to know what the rights of the elderly are. At that point, we engage the assistance of a lawyer, and by virtue of helping us out for that particular time, that lawyer is a palliative care professional. So there are various people, and today I feel like palliative care is the kind of field where people from all walks of life can engage in some capacity. Now, the first few are quite obvious. I don't need to explain them, but I would say that the volunteers form such a large part of our work. The volunteers, if you want to say that the admin and the medical team are the brain and the heart of palliative care, the volunteers are really our hands and eyes and ears and everything. So, and our backbones to a large extent, because it's through them that we reach out to the communities. So every single person that you see on that list is a vital part of the team. And the very last, even though it's mentioned last, I would say that person, the caregiver, is actually someone that we cannot ever sideline. At this point, I just want to take a minute to express a personal problem that I have with the word bystander. And that is something that we should never ever, we should try and never to call our caregivers, because he or she is the person who is looking after every need of that patient, day in, day out, long after the hospital, they've gone back from the hospital. They're looking after direct care needs as well as indirect care needs. What does that mean? Direct care needs means washing them, bathing them, feeding them. Indirect care needs means going to the bank on their behalf, filling in paperwork on their behalf, so on and so forth. The definition of a bystander is somebody who just stands on the side and does nothing. So I don't think a caregiver deserves to be called a bystander. And I think as professionals, we should all make that effort in our practice to stop using that word. It's a very, very important thing. So of course they are part of the team. You're wondering why the caregivers are there. It's because we believe in shared decision making. And we'll come to that in just a little while. But when determining somebody's plan of care, we have to consult with the family, because we can't decide what's good for them. We need to understand what the family's particular challenges are, and keeping that in mind, we have to come up with the plan of care. Okay, next slide, please. Who is the most important person on the team? This is something for all of you to think about. And if any of you would like to answer that question, please raise your hand and give me an answer.
Yeah, CCF team has some answers. Please, ma'am, proceed. Cannot audible, ma'am.
So my answer was the patient is the important person.
Okay, Smriti ma'am, the answer is patient.
All right. Does anyone else have any other answers? Okay.
Yeah.
That is, of course, that I'm glad to hear patient rather than doctor, because early in my career, the answer I used to hear most often was doctor. Of course, he's a very, very important person, but not the most important person I'm talking about. I would answer this question by saying that the person who is the most important person on the team is the one who can, at that moment, be of most value to the patient and the family. And that changes from time to time. It could be the nurse who comes in and administers the medication.
Smriti ma'am, we have one more answer.
Sorry, Vaishnavi?
Yeah, we have one more answer.
Yes.
Devtirtha, sorry.
Yeah, hello.
Yes, you can
Hi.
Yeah, what was my answer? Smriti ma'am already said. So that was my answer, that everyone in the team is most important. It depends on the person who is playing the role. It may be the doctor, it may be the social worker, it may be the psychologist, it may be the volunteers, or it may be also the person who is close to the patient is able to make more comfortable. So Smriti ma'am already told, so okay. Thank you.
Thank you, Devtika.
Yes.
Also, the fact that it could very well be the person who comes in to clean the hospital room and sees the patient crying and holds the patient's hand. It could be anybody who provides the patient and the family with the support that they need in that moment. And that could be anybody. So that's the answer to that question. Next slide, please. Now, what does it take to have an interdisciplinary team? It's not easy to have so many different kinds of people in one place with different kinds of expertise, different kinds of egos, different kinds of life experiences. I mean, in an ideal setting, the interdisciplinary team would get together, have a discussion about the patient and the families, come to a gloriously beautiful consensus and execute the plan. But that's not how it works. That's not how it works. Very often there are disagreements. A social worker might feel that, dealing with a person's financial crisis needs to be the first thing that we do, whereas the nurse might think it's something else. The occupational therapist might think it's something else. The physiotherapist may say, listen, before you do any of that, we need to give physiotherapy to the patient. So we have disagreements. We have disagreements, but here's where positive leadership becomes important. And when I say positive leadership, I don't mean that any one person takes leadership responsibilities all the time, because then that wouldn't really work. But definitely for every meeting, there should be a facilitator who can moderate the sessions and can help the team navigate through some of the difficult challenges with every case. Now, creating an atmosphere of trust where contributions are valued and consensus is fostered. This is important, trust. You have to be able to trust your colleagues. You have to be able to trust that your colleagues will respect your opinion. Now, that is not something that is easily earned overnight. Just because I come in with a particular kind of degree and background does not mean that my team will automatically trust everything I have to say. So it's a constant process of working with each other, and a leader's job also here is to make sure that conflicts are resolved rationally and maturely. And there are times when you can agree to disagree, but at the end of the day, everyone should remember that we are here for the patient and the family, and not for our own egos and not for our own agendas. Ensuring that the necessary resources, infrastructure, and training is available. Now, this is something that all of us as professionals need to look into, because we also need constant upgradation of skills. I am so thrilled that this ECHO program is happening, because very often it's the psychosocial clinicians who don't have as many avenues and opportunities for learning and training. So, but this is something that as a team, we have to constantly make sure that this is available, and that the whole team benefits from it. Next point, please. Now, ensuring a good mix of skills, competencies, and personalities. What happens when you have two people who disagree with each other on the team, or you have two people who have historically never worked well together, but at the same time their competencies are very, very they're remarkable in their competencies. They're very good in their own fields. They're extremely good with their skill sets. Now, it falls upon the leader to make sure that these personal clashes don't get in the way of the larger picture of helping the family and the patient, and to constantly bring the focus back to that. So that's a very important thing. Next slide, please. Okay. So what I was saying in the last slide, I think you need to go. Yeah. What I was saying in the last slide was that we always need to remember that it is the patient and the family that we're here to help. So it's person-centered. It's that person-centered. It's not got to do with who gets credit on the team, who has decided on what, and therefore has to be given the lead. So it's not like that. It has to be a well-integrated and coordinated care that is based on the needs of the patient. And the second point, which is to involve the patient and the family in all aspects of their care. Now, not everybody might agree that involving the patient and the family is wise, but in palliative care particularly, I think we give a lot of importance to the idea of autonomy and self-determination and dignity. And how do you ensure that a family's dignity is maintained? By not making decisions for them that you think are best. So, some of you have attended classes on dignity therapy with me, and that is something that we talk about where, the word dignity is like love or joy. You know that it's important in your life, but what it means to different people is different things. And the question really is then to ask the family and the patient, what can I do to help you preserve your dignity? What do I need to know about you that can help me help you better? And then whatever it is that they tell you, you need to incorporate it into your plan of care, because only then will you be doing them a service. Okay, avoid a paternalistic attitude. Paternalistic attitude is basically when we talk down to our patients and the families, when we make decisions for them, when we behave like we know what is best for them, and we don't take any of their opinions into consideration. And that is something that happens very frequently, and the most well-meaning of us tend to do this even unintentionally. Very often I've encountered in the course of the last many years, especially when there's a child in the picture. If the patient is a child, how many of us ask the child what he or she wants? We talk to the parents. And we will even talk to the parents and say, what is the child's name? How long has he been sick? And then sometimes you'll pat the child on the head or pull his cheeks. And that is paternalism. That right there is paternalism. The question there is, but how do we talk to children? We will be doing a session on that. There is a way to communicate with children. There is a way to engage them. Now, that is a very easy example. We do that with the elderly as well. We make decisions for the elderly. We speak to their children about what is best for them. And we deprive them of their autonomy. So that is something also that we do. We don't even have to go that far. You just have to walk into any, quite a few hospitals, and you will find that, we talk about the patient in the patient's presence, and we make decisions for them. We'll talk to a first-year student, medical student, and get their opinion, but we won't get the patient's opinion. So that's paternalistic attitude, and we should avoid that. Now, empower them to speak up and contribute to decision making. When the them here is the patient and the families. Empower them to speak up and contribute to the decision making. Very often the patients and the families are so bullied by the healthcare system that by the time they come to us, they feel like they don't have a voice and they don't have a right to speak up. Because right through their healthcare, they've been told what's good for them. They've been told not to ask any questions. Or if they ask questions, very often the questions are shot down. So by the time they come to us, they're quiet. So it falls on us to empower them and get them to speak up, get them to be part of the decision making, and constantly listen to what they have to say. Next slide, please. Requirements again is ensure team members have clear goals and understand. And I'm going to just sort of go through this very quickly because we've overshot our time quite a bit. participate in joint assessments, diagnosis, and goal setting, recognize the overlap of knowledge and expertise from staff from different disciplines, encourage less experienced team members to ask questions, bring out the alternative perspectives, establish teams with members from different disciplines, and organize regular team meetings for high levels of innovation. So that regularity of the team meeting is very important. Sometimes we get enthusiastic, we meet once every week and then we forget about it for 6 months. That cannot be the norm. Next slide. And of course, communication is very important. The fundamental, the foundation of any good team is good communication. And I'm going to leave this there. These slides will be shared with you. And if you have any questions regarding any of these points, you're welcome to write to me and I'll be happy to talk about it. But you're also going to be having classes on communication with Dr. Biju Raghavan. So I'm not going to tread on that. Next, please. Yes, I'm done, and I'm going to be here. So towards the end, when we have discussions, any questions, if there are, I'll take them.
Thank you, Smriti ma'am, for your wonderful introductory session. It gives us more information regarding how we need to approach in interdisciplinary. So thank you so much. We will have a discussion at the end of 5 minutes. So now we are having Ms. SHERIN WILFRED, who worked as a medical and psychiatric social worker with Pallium India. So she will explain the role of a social worker in palliative care and especially dealing with interdisciplinary. Over to you.
Good evening, everyone. So I'll be talking about the role of social workers in palliative care. So before that, I would like to start with the social worker definition, which was proposed by Anderson during 1943. And it says that it's a professional service rendered to people for the purpose of assisting them. It can be in an individual or in a group way to attain satisfying relationship and standard of life in accordance with their particular wishes and capacities and in harmony with those of the community. So I particularly quoted this because I felt that this is more applicable to what we do in palliative care. That's why I mention it, because the other definition talks about purposeful knowledge, skills, and everything. But this is like it starts with the building a relationship. So, so the first role I'd like to talk about is about a role of a case recorder. That means in a non-medical evaluation or case history. We know that I hope last time you remember the model of palliative care, where we talk about the physical aspect, then social, psychological, and spiritual spectrum of treatment. So this is the same, like we social workers are more into looking into the psychological and spiritual and social aspect of well-being, and that's why our assessment is more depend upon the all three areas of this. And it is by exploring the cultural belief and values that require clinical adaptation and accommodation. We'll understand what condition or what mind of state the patient is in, and this is much more helpful for us to understand beyond the physical thing. For example, maybe some patient may be having pain, as Smriti Rana said. They'll be having pain score for 8, but the doctor may not find the symptoms for it. It can be physical. Adding to that, so our duty is to explore the explore their problem, what their problems are, and to understand why they are having grieving or why they are having those things. And it's also help us to understand, like not only with the patient, we also talk to family members And even if we find that there is a conflict, then we conduct interdisciplinary family meetings. That is very useful in many of the cases, like what we observe. And we also give what to do next, clarifying their directive and identifying an appropriate surrogate decision making. Sometimes, very often, most of the caregivers are women, maybe the wife, and they don't have a say in the family, particularly when someone else is providing like supporting with this finance. So we need to understand who is the decision maker of the family. This also help lot in providing good care for the patient. So that is also a one prominent role for the caseworker. And then assessing literacy and language needs and providing appropriate education to inform this decision of treatment option. What happened is, when I met a family in a palliative care unit, children's palliative care unit, the family was told that about the prognosis of the child. This is like the child is in his end of life, but the doctors had clearly noted that it is mentioned that the prognosis is discussed that the child's condition is bad, but the family doesn't know the term means bad, the English word bad. So literally they don't get the idea of death. So it's our duty to understand whether they are whether they know about the terms which we use in regular basis. So we need to explain to them all about it. Then the next is like assessing the team to monitor patient family satisfaction with our care. So it's always good to understand what to get a feedback from this patient and family members, so that we can improve our quality service provided. So I think after taking a good case record from or case history from the patient, we eventually build a rapport with the family. That is a professional relationship with the patient, so that it creates trust in the social worker, so that they open up more about their inner thoughts or like hidden worries, everything with us. So this is like through empathy, we can establish a professional relationship with them, like build trust with the family members. And then what we can do is like we can take up the role of a counselor, where I have particularly divided some of the areas. Like first, if it is with the patient individual base, you can like be a personal counselor or a social counselor, where you can tell them about what can be done next, what are the availabilities they have in the community, all those things. Then like their family counseling, as I said earlier, if there is some conflict within the family, we can arrange a family meeting and talk to each of them, so that the primary caregiver does not get burdened so much, like they don't get the burden of caring alone for the patient. We can allocate, like we can find who else can contribute with the patient care. Then the crisis or grief counseling, that is one of the major thing what we do in palliative care, because most of the time when they come to us, they are in shock, because or they'll be facing the stages of grief, because they came to know that this is the end point and there is nothing they can do. So it is very important to address their grief and provide counseling regarding it. And also rehabilitation can be like when they go back to community, what else they can do, how they can improve their life, and which include quality of care, like everything. So we can counsel them regarding that. And bereavement counseling is much more different when it comes like the patient died, and then we are providing counseling, bereavement counseling for the person who's left behind, who was caring for the patient, or the family members. It can be children. So that is also very important. And this says that like our care does not end with the death of the patient. We continue for the family also. So another role what we can adopt is a patient navigation. That is like we can be an advocate or an educator or a facilitator. We can guide the patient and family through the healthcare system, like what they can do if it is in the community. If the patient is coming from a far distance, which is the nearest point they can get support from. We can tell them those information, and also like advocating for the patient rights and needs, especially with the vulnerable patient. It's very important to advocate their rights, because they'll be misused by most of the like settings. What can be like they'll be neglected, their rights will be neglected, and they are more vulnerable. So this is a very powerful point, like where we can advocate for them and also respect their dignity and provide good care for them. And education means mostly like we can educate about the medical diagnosis and prognosis. Which I mean is like disclosing about the diagnosis. Maybe most of the time the patient may not know what the condition is, so it's the duty of the social worker or the role of the social worker to go deep into it, do the risk assessment, and then see whether the patient is ready to take this information, like whether they are willing to take it. That is very important. So it takes a lot of time. So it's very important to educate them with the diagnosis and prognosis, and also regarding the patient care. If they are taking medicine, if they don't know, what kind of medicine they are taking for, we can educate the family members also. Then when it comes, these roles can be taken to our team itself. Like we can tell our team what regarding the patient, what the patient wish for, or like what is the problem. Is it right to talk about the diagnosis in front of the patient? Because the patient's mental status is not like he's not coping well, then it is really difficult. So we need to educate our team also regarding the status of the for the status of the patient. Then we can facilitate about the resources, which can be like government resources or like opportunities they have, and inform them about the nearest services, all those things. And this is maybe we have done this thing in while we were doing our MSW programs. Most probably we have seen like we come across with doing fundraising activities, everything like that. So similar to it, we can we should consider patient in the environment approach. We should consider that, because when the patient is in the unit, I mean inpatient unit, we only know about what they are expressing it, but we don't know what when they go back to their personal home, what the condition may be. For example, if a paraplegic patient is here, the first thought might be to give a wheelchair or something like that, but we don't know whether this wheelchair is the patient's house is wheelchair accessible. So those things we have to consider, patient's environment also. Then we have to provide support. So the most primary thing will be like social context of patient, influencing with the social context of patient illness. That is like I have heard from one of my patients that she would like to move away from the community. It's because like her family is restricting her from taking meeting her child, and she feels that this is like her cancer is contagious, so the children will also get cancer. So such thoughts are very like stigmatized thoughts. We have to provide awareness in the community, or like we have to educate those things. Then licensing with government and other non-governmental agencies. That is one important thing. We can talk to them about their eligible government schemes, what they can get, or like financial assistance. Most probably when a person stuck with a chronic disease or a life-threatening illness, usually they allocate all the resources, all their financial resources for the patient care, including their maybe including their child's education fund is relocated to patient care. So in those situations, we have to talk to the family and we can understand whether the child is getting drop out from the school, or whether they are denying treatment because of the financial burden. That is very important. So we can talk about that, or like we can find resources from the community, or find we can talk to arrange things from the government. Then help from the community, as Smriti Rana said earlier. Volunteers play a very good, like very important role in palliative care. Most of the time, we won't be able to approach them in emergency cases. Approach means in the sense when they call for an emergency situation, we won't be able to reach them. So if there is volunteers in the community to support this family, it will be very helpful at that time of emergency. So we can link with volunteers, or like identify volunteers from the community. That is another role. And then forming a connection with larger healthcare system. That is, as I said, where if there is a nearest hospital, like primary health center, or like community health center, which is like they can provide this kind of medicine, sort of treatment is available, we can approach them also. And also in certain cases, we have even provided a medical certificate from the doctor as like reference. In case of emergency, they can see that this patient is allergic to this medication. So the nearby hospital will able to understand, what condition the patient is going on. So this is in short about our roles. And if you have any doubt, please let's talk in the later, like towards the end. Okay, thank you so much.
Thank you, Sherin. Thank you for explaining the role of social worker as a networker, mobilizer, catalyst, facilitator, guide, and I don't know what else we can add into that. So thank you for explaining all those. Now we have a 5 minutes discussion and we can move to the next case presentation. So if you have any doubts, any comments regarding these two sessions, you can explain. Yes, Pranab Kumar sir, please.
Yeah, I think this interdisciplinary approach is a dynamic one. It is a dynamic approach, so it varies from case to case. I think the team performance varies from case to case, isn't it? It's a dynamic approach.
Yes.
Yeah. And another question is, to my mind, it comes that what are the characteristics of a good interdisciplinary team? What are the characteristics of a good interdisciplinary team?
So that's a question to you, ma'am. So what are the characteristics of a good interdisciplinary team? So
Please.
I suppose foremost among, okay, so some of it was in that slide where the characteristics would be one, mutual respect for each other's disciplines, a willingness to listen. That is a very, very important characteristic, not just to the patient and the family, but also to one another. And be able to be open to ideas brought to you by somebody else with a different kind of training and different kind of background. I think a good interdisciplinary team looks into diversity is seen as a good thing, and the team has to be able to resolve any conflicts that they might have and arrive at a shared decision-making capacity. So healthy respect for each other, good communication skills, or at least have a facilitator who can inspire that and moderate it. That's a characteristic that is definitely required. And of course, an ability to listen to the patient, to the families, and to your colleagues. These are the three things that come to my mind at the moment. But this is a very good question that you've asked, and perhaps in our learning material, Vaishnavi, we will put in a paper on this.
Sure.
Thank you.
Anyone else is have any doubts or suggestions? Yeah. Pranab sir, please.
What is the difference between interdisciplinary team and a multidisciplinary team? Is there any difference?
No, there isn't. It's different terminology. Some people say multidisciplinary, some people say interdisciplinary, but ultimately there's not too much of a difference.
Okay. Thank you.
So we are going with short of time. So if anyone is having any doubts or suggestions, comments, please raise your hands. If not, we can move with the next session. Okay, so thank you. So I welcome Mr. Lithin Abraham, our senior social worker, to explain a case presentation in front of you.
Good afternoon, everyone. My name is Lithin Abraham. I've been working in Pallium India since 1.5 years. So here we have a presentation about a particular patient who is under the care of Pallium India. So it's a female. We can't, as a part of the confidentiality, we haven't disclosed the name. So she is 42 years old and she was diagnosed with juvenile diabetes. Next slide. The complaints, physical complaints which she had were she had pain and she had an ulcer on her left foot, and her vision was quite blurred. And from the ulcer, she had a bleeding. It was continually bleeding from there. So the initial time when we saw this patient was like this patient was actually in a hospital. So we had gone along to see her. So when we went to her, we had taken a psychosocial history, and what we were able to find out was that she is having those physical complaints, as well as she was actually living with her son, who is just 11 years old. She had only one son, and her husband actually had abandoned her since her diagnosis was confirmed. Though she had like juvenile diabetes, but as she grew up, and after her she gave birth to her son, she lost that sensation in her lower limbs, and she wasn't able to have a proper physical relationship with her husband. So as a part of it, he left her. She was earlier working as a housemaid, and gradually what happened is like she started losing her eyesight, and also the wound on her leg was also trouble for her. And so the present situation was like she wasn't able to see, and she was having a wound. She wasn't able to move freely. And the other thing was like there was no breadwinner for the family, and the child wasn't able to go to the schools properly, and there was no support from her immediate friends or relatives also. So we also had an opportunity to go and visit the place where she was living in. When we went to that place, we were able to find out that the house was like made of all wooden planks which was attached around. To be very frank, to say like a normal person can't sleep over there. And also she was lying down on a tarpaulin sheet which was on the ground, and the ground was also not concreted enough. So she had the wound started it continued to increase because of there was no proper care for the ulcer also which she was having on the leg. So completely a bad state she was actually leaving also in, and for a meantime the community health center over there, they had actually because she was admitted over there, she was actually presently surviving over there in that place. And there was no and in the very place where she was living in also, there was no proper bathroom facilities, and quite difficult situation it was. Yeah, next slide. So the only support that she used to get was like one of her friend. She is actually the day when we went to see her, actually we saw that that person had come over to see her, and she just gave her 50 rupees to her. That was the only support which she was getting. And one of the person who like an assistant in the government hospital, who was a maid in the government hospital, she actually used to give some bring lunch and dinner for her and the son. So that was the only thing. And the husband used to give 600 rupees as a part of the education support which he used to give to the child. and that's the only thing that he used to support her for. So when we saw her situation, there were like, we understood that there were more than one concerns that she was having. So this was what was the psychosocial assessment that we had done over there. She was quite grieved, and the main reason for grievance was that there was nobody to support her, and the doctors had already told her that if she could do her eye surgery, she would be quite able to see and all. And and also her another biggest concern was about the child, that he's 11 years old, though the child was the primary caregiver of the mother. So and there is nobody like to look after her, and there's nobody to look after the child, and he's also in a young age where there are possibilities for him to like deviate from the family and also. But he was a very good son, and he was taking care of the mother so much, and she was just slightly able to walk. She could just go to the bathroom and all with the help of a walker. And so her concerns were like she wanted somebody to support her, and she also wished to have a house. And also what she told us was like, if her eye surgery could be done, and if she could get a small house, she could do something on her own which can help her to have a sustainable life in the future. And these were some of the concerns that she had presented to us. So this was the psychosocial interventions that we had done. Actually, as ma'am had already told about the interdisciplinary team, it was at this juncture that we actually needed to have a legal advisor. So we had to take the support of an advocate. Actually, that madam helped us to register a case at Childline, and we also filed a petition at the district Child Protection Unit also, and they told that they will be protecting that family. And the next thing that what we could do was like, we arranged with the help of a local community volunteer over there, we were able to actually arrange 3 times meal for that family, because they weren't getting proper food and all. So we were able to provide it for her from a nearby hotel. Actually, that was being taken care of by a community volunteer. And thirdly, we actually helped her to get her a disability certificate, and that was also quite helpful for her. Because of that, she could easily apply for a disability pension. And also, with the help of the advocate itself, we were able to put this matter into social media, and a lot of people who saw the matter, they actually told that they will be providing some financial assistance for her. And also, when we had gone to when we registered the case at the Child Protection Unit, so actually they had asked us to have a contact with the TLSC, it's the Taluk Legal Service Corporation, and they actually took a role, and they made sure that she got a ration card, and that was like, I think, one of the quickest time a person had got a ration card. She got it within a week's time. So that was something which was very better. I felt that it was something good thing that TLSC could do for her. And also they from the help of TLSC, she was also able to apply in Panchayat to get a shelter facility. And and so we also managed to get her a temporary home, in which and also the expenses were managed by another NGO as well as our institution. Also, another concern which she was having was about her eye surgery. The biggest problem was that her diabetes wasn't being regulated properly. So what we did was like, we admitted her to our institute, and our healthcare team monitored her diabetes, and actually we were able to control it, and her eye surgery was done. And actually something which she meant, which she said after the eye surgery, was that she was able to see her child after 4 years. So that was something which which actually encouraged us a lot, and we were also very happy that at least we could do something for her with all these things. And also presently what we're doing is that we're continuing her wound recovery and management in a nearby hospital. Also for the son, actually he was always looking after mother's needs, and also we try to introduce him to a children's group which we have in it's like a summer camp. We have it in Palim, India. It's called Putti Kuttam, so he was also a part of it, and he spent like 3 days with them, so that was also something very much helpful for him. And we provided an educational support to him. And also what the present plan what we have is to have to get her to a sustainable income with which she but the problem is that her ulcer needs to get cured, and after that we can get her to uh, lead her to something so sustainable income which she could get it. Yeah. So the outcomes from all these interventions was that, as I had already told you, that she was very joyful as she was able to see her son after quite a long time. Uh, and also now her son is going to school regularly. Because she got the ration card, she was able to apply to all the eligible government schemes which is available. And her she got her disability certificate. And also presently she is getting a regular supply of food from the hotel with the help of the community volunteer. So she had a grievance in herself that there is nobody to support, and now the present situation is that she is very confident and motivated, and she thinks that she can be a small scale entrepreneur. So if you could just go back, you can see I have highlighted the multidisciplinary team, the team who engaged in this patient's well-being. One was the advocate, and the next was the community volunteer, the social media, the TLC group, the healthcare team, as well as all the nurses and social workers who were part of the team. Okay. So let's come to the summary of it. So I told you a lot of things. I'll just cut it down to this. We had a 42-year-old female having juvenile diabetes. So with the help of our interdisciplinary team, we could provide like good psychosocial interventions for her. And the social worker team played a great role in coordinating all these psychosocial interventions, not alone, but with the help of the interdisciplinary team. So the patient was actually provided for holistic care. It's getting continued, and it has in one way enhanced the quality of life of the patient. Thank you so much.
So thank you, Litin. I think this practical experience, real life experience, give us more importance and more knowledge about the importance of a interdisciplinary team in dealing with patient care, especially the role of social worker. So, is anyone is having any comments regarding the entire session? Please. Yeah, Pranab sir.
Thank you. The entire session is mind blowing, I think, and we are enriched with different knowledge of the disciplinary team. The approach is the goal to a cohesive betterment of a patient with the help of coordination from different discipline expertise. And I think this session is very what to say, very enrichment. Okay, thank you very much.
Thank you, sir. More we want to learn, more sessions are coming up with more enthusiastic and more realistic approach. So, is anybody is having any other comments? Rebecca, ma'am.
Can you hear me?
Yes, please.
Yes. In the Western scenario, we usually have a clergy who comes in the team, especially for spiritual counseling. My question was on the understanding of how much does a clergy need to know for the spiritual help? Like, do we consider him a part of the team, or is he like some external resource person? How do we include a spiritual counseling part in this?
Yeah. Thank Thank you, Rebecca. I think that's a very important question. Firstly, I just want to say that when we talk about spiritual care, it goes also beyond faith and religion. It is about anything that brings meaning to that person's life and brings them a sense of connectedness to the universe, to other people, to their community. So just so that everybody is clear that when we talk about spiritual assessment, we're not talking about religious belief only. Having said that, of course, there is a place for our faith, and depending on what it is, what the requirement of that patient is. So we actually have something called a spiritual assessment tool, and I don't want to get into it right now because it's quite a huge thing, and we are actually doing a session on spirituality further down the line. But it allows us to understand what it is that is important to that person in terms of connectedness, meaning, hope, maintaining hope, positivity, all of those things. Depending on what emerges, if we have to engage a priest or someone from the clergy or an imam or anybody that the person needs, we will do it, and it will be done in a way that is respectful to the family, and the whole family is in agreement with it. So at that point, you can consider that person to be part of the team, because I think the person will be given some sort of background as to what the patient's concerns are, but I don't think we need to go into a lot of detail into that. It becomes a very intimate conversation also between the patient and the person coming to guide. So I hope, I know that's not a very crisp answer, but I hope I've managed to address it a little bit.
Thank you. Thank you, Smriti ma'am. So, is anyone having any other questions? Yes, Tabinda, please.
Yeah. Okay, am I audible?
Yes.
Yeah. Fine. So the case summary that Sir has shared with us, I would like to know, it's not basically a question, it's just I just want to know that what challenges do they face while providing the psychosocial support to the patient or while providing other kind of support? What kind of challenges they face, and in what manner that they face the challenges and try to sort it?
Yeah, the challenges and how you are managed.
The challenges actually, I actually didn't face any particular challenges, because as it came up, we were actually able to provide it time to time. So somebody else would like to say anything about it?
Yeah.
Yeah, so actually the problem, what I can tell you is, like, when we went to the patient, the thing was like, there were a lot of concerns which she was having. She had a physical concern, she had a psychological concern, a social concern, everything she was having. So the biggest challenge that we faced was like, to which thing we have to give priority, first priority which we have to give to. So we had an interdisciplinary team meeting. We discussed with the whole team, and on the basis of that, we proceeded. That's something that we can do, because as already it's been shared, that we can share everybody's idea. We can get the efforts and ideas of everyone, and together we can bring out a positive thing that we can do for the person.
And I can add one more point, that it is not within a one-day time we solved all these problems. It took, correct time, dividing the duties and debating with, facilitating with all other resource persons. So it take considerable time to resolve all this. Smriti ma'am wants to say something. Yeah.
Thank you, Litin and Vaishnavi. I think also the point that you brought up about knowing how to prioritize, that is something that that can be a huge challenge sometimes. But the other thing is, I just want everybody to know how we sort of run things a little bit. We have several patients and families registered registered with us. But those patients and families that have compounded issues, we have a special group called, which we consider especially vulnerable families. Families that may have more than one person who is sick, or the caregiver itself has several issues. So, a family that is going through several extremely difficult problems at the same time comes under our vulnerable families group. And I think the strategy is that with the vulnerable families, we try and see them more frequently as we would other families. We keep track of particular aspects. If there's a child involved, we have a volunteer also following through on that child. So we decide to pay, perhaps you could say we decide to pay a little extra attention when we find that a family is particularly vulnerable. So that identifying those challenges can sometimes be a challenge itself for the team.
Thank you, ma'am. So, any other questions? Yeah. So, I can't see anyone is having any questions. So, it's reaching our 4:30 time. And yeah, Pranab sir.
Yeah, it is the last question from me.
Sure,
Is there any clear synthesis of the essence of what makes a good interdisciplinary team and what such a team might look like? Could you hear?
Yes.
I think. Sorry, Vaishnavi, were you going to say something?
No. You can proceed, ma'am. I think it's characteristic features only, but if you can add some more points, that would be great.
I think the membership of the interdisciplinary team changes depending upon the circumstances. You don't always may need a physiotherapist on board. You may not always need an art therapist. You may not always need a, but the core team remains the same, which is your doctor, your nurse, your social worker, if you can have a counselor and a psychologist, and definitely a volunteer, and the family. That's your core group. But depending on the need, you have other people joining in from time to time. Like Rebecca had asked about the role of the clergyman. For a while, someone from the spiritual sphere can also be part of the team. But your core team remains the same, which in my opinion would be the doctor, the nurse, the social worker, the physiotherapist, and volunteer.
Thank you, ma'am.
So thank you so much, one and all. Yeah, for joining with us for this. I would like to appreciate all our 3 resource persons who have conducted the sessions in a very wonderful manner. Thank you, SMRITI RANA, for your presence, and in a short notice, she prepared to interdisciplinary team, and she explained it with practical case explanations and all. We started with the WHO palliative care definition and ended with we should remove the team bystanders instead of caregivers. So thank you so much for that. And Sherin, thank you for giving us a vast area of explaining the role of social workers as many. I don't want to count it. It is endless, I think. And thank you, Litin, for your practical case history explanation that gives us in what way we need to act. All the theory aspects related to this, in what way we need to act, that kind of explanation is related to that, to your case presentation. So thank you, one and all. Thank you, Rajalashmi, for coordinating all those sessions. Thank you, Arathi, for the technical support. Thank you, social workers, for your physical presence. So thank you, one and all. We will be seeing you in the next session, in the next Friday, 3 to 4:30 p.m. So we'll be get in touch with all the learning summary materials and all of the aspects. Thank you, Anna.
Special thanks to Vaishnavi too.
Thank you for this kind of interactive sessions. We would like to get more suggestions from your part. Then it will be more lively too. Thank you.
So I have provided a feedback link in the group chat. So I will be sending the same in our WhatsApp group too. So please log in and give your feedback. It's very important for us. So we will see you on next Friday with the topic on laying foundation on good practice taken by SMRITI ma'am. So see you all next Friday. We are logging off for today. Bye.